We have the pleasure of interviewing Dr. John Buster, who's a reproductive endocrinologist at Brown University in Providence. John, welcome.
Thank you, Hal. Pleasure to be here.
It's great to have you here. I have a group of questions I just want to go through so we can learn about you and hear about all the wonderful things you've done in your career. Tell me, we're going to start at the start. Where were you born and where did you grow up?
I was born in Oxnard, California, 1941.
Where's Oxnard?
Oxnard is about 100 miles north of here on Amtrak.
Okay.
I went through it yesterday. In fact, when I was born there, I even went to the hotel room where I was conceived on a vacation one time, called my mother and thanked her. She loved it.
I bet. You knew exactly the right room number, too. Huh?
I actually did.
And
I called her, and we both had a good time celebrating that event.
I'll bet. Well, having grown up there, what directed you to decide to become a physician?
My father was a very successful aerospace engineer, and he started during World War II, building military aircraft. He's a very techie kind of guy, entrepreneur type, and he was an inspiration to me about focus, a sense of purpose and mission. And he lived it and showed it to me and inspired me to do something like this. So when I was young, I daydreamed a lot. Teachers always thought I was kind of slow because I didn't pay attention. It was about doing something like this, and it happened. And I learned over the years that you visualize something and you really, really want it, you can make things happen. Human brains like that. So my father and my family lived that way and taught me that way, and that's how it happened.
Okay. Where did you end up going to college?
Stanford.
Oh, that's good.
Yeah, went to Stanford, and then I finished in 3 years. Went to UCLA and graduated from UCLA Med School.
Well, what in that experience drew you to obstetrics and gynecology?
The UCLA system as a student had us rotating through very active services, and in those days, many of the people that we honor today were they were senior residents. So amongst other people doing what I'm doing right now, 2 of them were my senior residents. We all trained in the same space, and they inspired confidence and wisdom, and we had fabulous professors. I wanted to be like that.
And so it was the professors there at UCLA that really motivated you to go into OBGYN?
Yeah.
And then where did you do your residency?
At Harbor, UCLA. Dan Michelle was the chair in those days. Later on was John Marshall. But I was surrounded by good people all that time. I wanted to be like them. They were good examples.
Well, you know, your father being the aeronautical engineer and into innovation, maybe I'm not surprised you decided to go into reproductive endocrinology.
That's where the action was. And I remember a conversation I had with John Marshall, who was our chair at Harbor for like 14 years. And I was thinking about going to oncology. He said, well, if you want to just operate on a dead end, go ahead. But I have something better for you. Go in the lab and learn a skill. Learn a very special skill in the lab. And if you want to come back in a year and go to oncology, fine. I never went back. Went into the research lab, and I had a superb mentor, eccentric scientist named Guy Abraham. He developed the first estradiol RIAs, and he taught me the craft. And as a fellow, I was developing RIAs that are used today for DHA sulfate and estradiol. I did that as a fellow.
You actually discovered the radioimmunoassay for dihydroepiandrosterone sulfate.
I described the first one.
Yeah.
We did it straight in blood, and I did it not because I was genius. Abraham knew how to make antibodies, and the ones he made were so good, we could measure directly unextracted serum. That technique is still used today, in much high modified, of course. DHA sulfate. So I described, as a fellow, the first RAs to measure DHA sulfate straight in plasma. So now it's how it's done.
Interesting, because now it's done all the time.
Yeah.
And the estriol that you discovered how to measure, tell us a little bit about that.
Well, we had a good antibody for it, and we were able to measure it without chromatography. That made it clinically usable. So,
is that like thin layer chromatography? Is that...
We used sea light.
Okay.
Back in those days. But with this assay, the antibody was so good and so specific, we could measure estriol in the simple extracted plasma, so you could do it in large numbers. So I worked on that as a fellow and then took it off. I was in the military for 2 years. I just kept doing it, published a bunch of papers on it very early in my life. So I was very, very secure with the lab and liked that, and never went back to the operating room for oncology.
Well, how did you end up balancing being a laboratory researcher and being a clinician? How did that integrate for you?
I think I was really meant to be a clinician. I just enjoyed it. And I practiced for 50 years, reproductive endocrinology. I wouldn't trade for anything else. It was a wonderful experience to provide what was state-of-the-art things to our patients. And the lab experience really helped me do that. Because I was very secure in the lab, I understood laboratory testing, how to do it, how it worked, and I was very secure explaining it to the patients. So I enjoyed 50 years of practice, and I did great. It was just a wonderful experience.
Well, you know, I think a lot of us find when you can educate patients about what you're doing and why you're doing it, they certainly become much better patients.
That was my experience, and record speaks for itself. I did pretty well.
You've done very, very, very well.
Yeah.
So when you finished training, you went into the military for...
Yes.
Army, Navy, Air Force?
I was at William Beaumont in El Paso for 2 years during the Vietnam War, just had finished, and I had a lab skill, so they gave me a lab. I published papers there. They liked that because it gave them credibility, but they had incredibly good patient population. They knew how to take orders. You get stuff done. And they were so appreciative of somebody that could do that. So I had a lab published quite a bit in the military. It was a very close relationship, and I have been back there as a consultant many times since those days.
When you came out of the military, what was your first position then?
I was on the faculty at UCLA. I remained on it for 21 years, but I was working mostly at Harvard General. And I had a lab there, and I had good support, and did quite a number of projects related to steroid immunoassays. So did a lot of work with fetal sheep for a while. But then what really hit the jackpot was when we began doing embryology. And it was just after the first in vitro birth. We thought we would exploit the virtue of the in vivo fertilized egg. And so we went to some cattle ranches and learned about uterine lavage as a method to recover blastocysts from cows with. And we adapted it to human beings. And early 1980s began to work with uterine lavage as a method to acquire the human blastocyst. In that case, we did it for transfer. In the 1980s, early 80s, in vitro was not doing well. The success rates were 5%. There was no way to get eggs except a laparoscopy. It didn't seem very practical. So we thought about...
that was right after step-toes. Mrs. Brown was what, 78, 79, something?
It was 1980.
Or 1980.
Just after that, we realized that the technology developed in animal husbandry had worked on 8 different species of animal, and you could adapt that to human beings. It was so simple, but you had to find an easy way to extract the embryo from the uterus of a woman. And so we miniaturized that technology, spent a lot of money. We had to finance it with Wall Street money because there was no federal grant money to do anything like this. And we got to work. And the actual first human donor embryos came from this, not IVF. We washed them out and transplanted them, and they became babies. And we learned in 1983, 84, that the human in vivo blastocyst is phenomenally tough. And we were getting, in 1983, 84, getting 60% ongoing pregnancies per single blast transferred. Phenomenal. And from that work came all the interest in IVF in culturing the blast day 5. So I claim that they got from us. And what an opportunity that was. So we made that work, and we got pregnancies doing it. But it wasn't very efficient in the 1980s. We were not able to do it also because the paradigm involved using sperm from a man was not the husband of the woman to get the donor. So when HIV came in the picture in 1986, we had to stop work on it. Broke my heart.
Because it was really the ultimate adoption.
Absolutely. And we received incredible criticism for it.
Yeah.
But look what happened.
Oh, yeah.
That first birth was in January 1984. The first of over 500,000 kids that become donor embryos. I think that's pretty cool.
I think it's amazing. When you step back and look at the 50 years that you have been a reproductive endocrinologist, there's probably in no area in OBGYN, and maybe not in medicine in general, has there been such a technological breakthrough in that time period.
That particular event, I lived it. I took incredible criticism for it because it was different, but it worked. We abandoned it because of the HIV problem.
Right.
So we left it on the shelf. After that, I knew it was going to come back. And the reason it was going to come back was because of the opportunity to study the human genome in the embryo formed in vivo. So we left it on the shelf for 30 years. I knew it was going to come back. And about 8 years ago, I began staying home on Saturday night. I worked on patents for this process and got patents on all the devices and had them issued. And then was able to start a company to build them. And now they're back. And you're going to be seeing some exciting things happen because this method allows us to access a human genome without IVF.
Right.
A lot cheaper, simpler, patient will find it more acceptable. So right now,
because you can take the blastocyst out
of the woman's body.
You can do PDG on it
and freeze it.
And or reimplant it.
Right, well, you will reimplant it if it's okay. But it's lots of things happen together to make this possible. So this has been going on in my life for the last 9 or 10 years.
You've had so many wonderful things that you've done. I mean, obviously, the embryo transfer is a major one. What other things would you like to highlight as the pinnacles or high points in your career?
Well, the development of uterine lavage was dealt with lots of setbacks and adversity. It was going against the grain, but it was the right thing to do. I was focused on it. And so we had issues with it. One of them was the fear of ectopic pregnancies. So we developed methotrexate to be able to say to our patients that, hey, okay, you get this problem, we have a medical therapy for you, you don't need to go to laparoscopy. That's how it got started.
Right.
So we published the first papers on that in 1985 because we did it. It took some courage and a little bit of daring. Had to be young. I wouldn't do it today, but my gosh.
It totally changed the treatment of ectopic pregnancy in this country.
We introduced methotrexate and took all kinds of stuff over it. One meeting, I remember, it was a SRM meeting in Canada. This surgeon stood up and said, Dr. Buster, how can you have a fellow presenting stuff like this when you're poisoning women? And we can take a laser and zap an ectopic pregnancy with no problem at all. I just said, you don't get it. And it stayed. And within 3 years, I had people saying at meetings, hey, try it, you'll like it.
Let me ask you, what's been your involvement with ACOG?
Well, I've served on quite a number of committees. I've given post-grad courses. I've learned it's a great way to learn how OBGYNs think. I've served on a number of things over the years. ACOG has been very important to me in understanding how the doctors think. It represents their opinion. It teaches them good principles. I've written a number of things that have gone published by ACOG, which I'm very proud of, related to ectopics. I've been through the committee process. I've been beaten up, shoot up, but it's by good people.
Yeah.
So I like doing ACOG things because I like who's in it. And I've always felt good about it. So it has had a lot of influence shaping what I've been doing, because I get opinions from people in the committees or in person by coming here. And I thrive on it.
Let me ask you, you've seen a lot of changes in OBGYN. Would you still recommend OBGYN to a young physician as a specialty today?
Absolutely. I wouldn't change anything about it. I thank God for those 50 years I had it. And we've just grown up together. But I think that what we take care of is the most vital entity in the universe. And that's children and pregnant women. I think that to care for them is an absolute privilege. And I've always been in awe of it. And ask about my mother, she inspired that. And she made me respect women, and because of who she was. And about the childbearing process, it's very close to God's heart. So that's where I am today. I wouldn't change it for the world.
Do you think there are any negative aspects of our profession today?
Yeah, you can't sleep at night. So I picked up reproductive endocrinology. And
Then you could sleep at night. You didn't have to get up and deliver babies.
I worry so much about it. With things that we've done, like lavage, affecting so many people, the pre-implantation genetic disease diagnosis is going to have a profound effect on humanity. Mm-hmm. Because of lavage, as you're going to be seeing this next year, because that product's going to come online now. We are going to be serving huge numbers of women. Look at the meeting right now, all the posters up there about getting prenatal testing.
All right. Yeah, I was going to say, where do you see the future of genetics in our specialty?
Well, first of all, at this meeting, you have all these diagnostic companies out there. Now, I know these guys. I work with them now, so I know how they think. They see huge business opportunity. What I see is a great advancement in maternal health, where so many diseases that have issues with genetic configuration can be diagnosed in a blastocyst, where you can do something like lavage in normal. I've been for infertile people. Most women aren't infertile. Most women get pregnant pretty easily. They are great for lavage because we don't need to do IVF on them. So we're going to be able to serve about another 80%, 90% of women that won't do IVF. They don't need it. They will go with a thing like lavage, have their embryos removed if there's an issue, have a profile done on the blastocyst, and freeze them. And eventually you're going to be able to repair many conditions with things like CRISPR, where you can rearrange the DNA, and you never experience the illness at all.
At the blastocyst level?
Yes.
Yeah. The ethical issues that are going to come down the pike for us as a specialty or in reproductive endocrinology, when we can do these testing and do this therapy, how do you see us dealing with that?
I'm looking forward to it. I've been schlepping around the lab for years. I wanted to me, that phase in this technology is my last game. I want to spend the next 10 years of my life dealing with that, because I went through all this stuff over donor embryos. I nearly got tarred and feathered for that work, just because it was not what people thought was the right thing to do. Who said no one ever wanted. It's totally different than that. It was worth standing up to that and making it happen, becoming mainstream. But I look forward to dealing with these kinds of dilemmas. I think they're fascinating. I think we have the wisdom to deal with them now. And I think the opportunity to improve the health of women and their children and their husbands, by the way, because they're babies too,
Yeah.
is phenomenal. So just as one example, premature labor is a symptom. We can't see that baby. We don't know what it looks like. But there's a whole bunch of disease we don't know about that cause this. You're going to be able to identify the markers of that condition and preempt it. And I'm hoping that someday premature labor will be just history, because we will be able to modulate the fetal conditions that lead to that. So, but there's real big targets there right now are rare diseases, cystic fibrosis, sickle cell, all those that are devastating countries like Panama. Panama has a huge problem with sickle cell. To be able to go in that country and help those people avoid that, they're terrified of having children.
Right. I mean, the concept of genetic engineering and what we're going to be able to do is mind-boggling. You know, John, I knew this interview was going to go like this, you know, and I'm so glad that they're honoring you as a leading role model and at the ACOG booth at this meeting. You step back and look at what impact you have had in our specialty, be it DHES, be it estriol, being it embryo lavage and transfer. It is just incredible. I mean, you truly are a guiding light in the specialty of obstetrics and gynecology. And I know people, when they look at this interview downstream, are going to say, oh my goodness, this gentleman did all this. So thank you for all that you have done for our specialty and for the women of this country and the women of the world. And thank you for being able to be here and allowing me to interview you today. You are a great person who has done so much for all of us. Thank you.
Thank you, Hal. It's been a privilege.
It's been our privilege. Thank you.